接下来我们就是我刚刚提到的 Zach McCormick 医师哈，他会替大家讲。那传统来讲，我们在讲anterior column 的疼痛都是 focus 在 disc。那在最近开始有一些观念是讲到 Discogenic， 那他把两个东西合并在一起讲给大家听。那早上他的部分他会讲 diagnosis， 下午的部分他 focus 在 treatment。所以那早上刚刚有跟大家提到会给大家问到稿，所以如果大家手上现在 QR code 没有拿到，可以先把问题写下来，我们会想办法让大家可以得到问问题的机会。那我们现在开始。
Good morning, I'm Zach McCormick. I'm a physiatrist, pain medicine physician, and spinal interventionalist at the University of Utah. I'm grateful for the opportunity to be able to present, and my apologies that I wasn't able to make it to Chong and to Taiwan. Hopefully I'll get a chance to visit and meet everyone in the future. And thank you very much to Donald. So I was asked to speak on discogenic pain and then separately on vertebrogenic pain. And I've combined them a bit, and I think you'll understand why once I show you some of the content in the slides. But what I've done is broken this down so that in this first talk we'll cover diagnosis of discovertebral pain, and in the second lecture later on we'll talk about treatment. So part 1, diagnosis. These are my disclosures, nothing that's specifically relevant to what I'll speak about in this first part. All right, so we'll dive into pathophysiology of annular pain, and then separately vertebral end plate or vertebrogenic pain, talk about clinical features, and then interventional diagnosis and some of the challenges related. So just to level set, here we're looking at a vertebral segment, a motion segment. So we have obviously the disc and the bordering vertebral bodies, cephalad and caudal to that disc. What's important here is distinct innervation. And obviously as pain physicians, spine interventionalists, spine specialists, we obviously care about this deeply because there are ways that we can intervene on pain if we know where the path of nociception is. So at the end plate interface, these are basivertebral nerve termini. So that basivertebral nerve, it ultimately the takeoff from the sinovertebral nerve enters the posterior aspect of the vertebral body and then arborizes out to the end plate to create sensation to the end plate. Alternatively, the posterior aspect of the annulus of the disc is innervated directly by the sinovertebral nerve. And those fibers, they insert back on the spinal nerve itself. And so there is distinct innervation of the posterior annulus as opposed to the vertebral body end plate. So first the disc, I think most are familiar with this. The concept of discogenic, quote unquote, discogenic pain has been around for many years and written about extensively in textbooks and review articles and so on. And the concept here is that there is disruption of the internal aspect of the disc in which fissures develop within the annular fibers. And in some cases, those become painful. Others, they may not. This is a study that was done a number of years ago. This is an old study at this point, but where these investigators took a look at 19 discs in patients who had a history of low back pain with positive provocation discography. And then those individuals had passed away. So they were cadavers at the time of the study. And then they looked at matched controls, patients that had no history of low back pain, and they evaluated and compared the histology of the disc annulus in the respective samples of the individuals, the cadavers, that had had chronic history of back pain, positive provocation discography, and then matched controls. And what they see is in these fissures, in the folks with low back pain and positive provocation discography, there was an ingrowth of vessels and also of nerves, new nerve tissue, presumably coming from the sinovertebral nerve. That's what you're seeing in these stains. So what about vertebrogenic pain? Different concept. So this is thought to be repetitive stress injury to the cartilage end plate that borders the vertebral body and the aspect of the disc. So as there is repetitive stress over time, wear and tear, one can develop defects in the vertebral end plate that allows the ability of factors from the nucleus pulposus of the disc to migrate across the end plate. And in some proportion of individuals, not everybody certainly, but in some proportion of individuals, this leads to inflammation. So these factors in the nucleus are very pro-inflammatory in certain environments. For example, when there's a herniation in the epidural space, there's significant chemical inflammation around the nerve root, and that certainly can cause radiculopathy or radicular pain, which all are familiar with. Well, we see similar processes that go on within the trabecular bone and the bone marrow when those same factors essentially are allowed to migrate into that area. So in a subset of patients, why we don't know, but in some, there is a chemical sensitization and there is proliferation of nociceptors. So we know also that there's a relationship with modic change. So here's an example of an individual with type 1 modic changes. Edema, inflammation, and then the respective example would be, or counterexample would be the patient with the type 2 change, where there's fatty infiltration. In theory, this follows type 1 change. Though patients may stall and remain in a state of a type 1 edematous inflammatory modic change for a long time. Type 3 changes, which are sclerotic changes,